Hello, my name is Stephanie Mallahan, and I am an MPH in maternal and child health student. I completed my internship at the Tucson Medical Center, where over 5,000 babies are delivered each year. The Labor and Delivery Unit specializes in high-risk pregnancies, as well as offers support throughout pregnancy and postpartum by providing breastfeeding support, education, and other social services to patients and their families when needed. They also have a neonatal intensive care unit, or NICU. My project was to look at the medical records of babies who are born to mothers who are either using opioids or other drugs during pregnancy or who are on medication-assisted treatment, known as MAT, and assess the neonatal outcomes. Opioid abuse during pregnancy has emerged as a public health problem in the midst of the opioid epidemic that killed 116 people per day in 2016. One estimate of the admissions of pregnant women to treatment centers for abuse of prescription opioids shows an increase from 2% in 1992 to 28% by 2012. MAT with methadone, which is given to the patients instead of opioids and reduces withdrawal symptoms, is the current recommendation for the treatment of opioid abuse during pregnancy. Research has suggested that another type of MAT, buprenorphine, may produce similar outcomes for mother and baby when compared to methadone. Despite this recommendation, it is estimated that 55 to 94% of babies who are exposed in utero to either opioids or MAT will develop neonatal abstinence syndrome, or NAS. NAS is the process of the infant withdrawing from substances that the mother used during pregnancy, and this is usually seen within 1 to 5 days after the baby is born. The Finnegan scoring system is used to review symptoms that an infant is experiencing, and based off of that, they can continue to be monitored. The protocol at TMC is that after 3 back-to-back high scores, the baby will be treated for NAS. Some of the signs of NAS include high-pitched cries, stiffness in the arms or legs, issues sleeping, shaking or jitters, problems with feeding, vomiting, poor weight gain, and can also include seizures. The primary activities of the internship involved designing and investigating a research question, writing an IRB application, and then once I had approval from the IRB, to review the medical records for relevant data points and collecting and analyzing the data. Information that I collected included demographics, as well as the mother's drug use screen. This was done by a urine test at the time of hospital admission or right before giving birth. For the babies, this was confirmed by meconium testing, or the first stool of the child, and this is collected and can tell what was ingested while the baby was in utero after about 15 weeks through the end of pregnancy. Other points were outcomes such as gestational age at birth, birth weight, and birth length. I reviewed the records of 147 mothers and their babies who were determined to have been exposed to substances from January 2016 to December 2017. Of those babies whose records were reviewed, 67% were admitted to the NICU for NAS, while 33% were monitored for NAS. However, their Finnegan scores were not high enough to be admitted to the NICU. Among those who were exposed to buprenorphine alone, the mean birth weight and mean head circumference was greater than for those exposed to methadone alone. The babies who were admitted to the NICU were those who were determined to meet the Finnegan scoring criteria for withdrawal. Among the 99 babies who were admitted, 6% were exposed to buprenorphine and 29% were exposed to methadone in utero. The remaining babies were exposed to opioids alone, polysubstance and buprenorphine, or polysubstance and methadone. This is compared with 48 babies who were not admitted to the NICU, where 17% were exposed to buprenorphine and 17% were exposed to methadone in utero. The length of stay for those babies admitted to the NICU was a minimum of 5 days, an average of 28.8 days, and a maximum of 106 days. For those exposed to buprenorphine alone, the mean length of stay in the NICU was 14.8 days, and for those exposed to methadone, the mean was 33.4 days. There are 3 types of medication treatments for NAS. The first is morphine, which is used to control withdrawal symptoms in 58% of the babies. Next, if the symptoms aren't being well controlled, clonidine is added. That happened in 25% of the babies. And finally, phenobarbital can be added in addition. And this is only used in very severe cases and was used in 4.2% of the babies. Something else that was apparent as a potential public health problem was prenatal care, or lack of, for many women. Overall, 9.5% of the mothers reviewed had no documented care whatsoever, while 60% had limited care. Approximately half, or 49%, had adequate prenatal care. Although this is something that could potentially be expected for active polysubstance users, those that are maintained on methadone are seen in a clinic every day to receive their doses. So this highlights the potential opportunities that there might be to combine these efforts together. The findings for this population at TMC were consistent with the literature that concluded that the use of buprenorphine compared with the use of methadone as a MAT treatment during pregnancy results in a less severe case of NAS. At TMC, those babies who were exposed to buprenorphine alone had a greater mean birth weight than those exposed to methadone alone, greater mean head circumference, less NICU admits, and among those admitted to the NICU, a decrease in the length of stay. Thank you to my internship committee, the Polysubstance Abuse and Pregnancy and the Newborn Task Force at TMC, and the Western Region Public Health Training Center for the support of my project. If you have any questions, please contact me at the address here. Thank you.